Hi, my name is Jaron Chong, and I'm a body radiologist from Victoria Hospital. This is the presentation titled Transition to Clerkship Abdominal X-ray Imaging, where in today's presentation we'll be discussing an introduction overall to abdominal plain film acquisition, how we actually acquire the images, as well as we'll be reviewing abdominal radiograph anatomy, and finally provide you with an approach to reading abdominal radiographs. The first thing to start with out is the clinical indications of abdominal X-ray, of which there are many possible conditions or diseases that might indicate the choice of an abdominal radiograph that can loosely be divided into acute and chronic categories. For acute symptoms, things like suspecting a gastric or duodenal or bowel perforation to exclude large amounts of free air can be done very quickly with an abdominal radiograph. If a person has a colitis, an infection, or a C. diff infection, assessing the bowel walls, both for thickening and segments of inflammation, as well as a condition called toxic megacolon, can be done very quickly. And finally, the last category of acute conditions, bowel obstructions, be it small bowel or large bowel obstructions, can occasionally be seen on radiographs as well, with a partial sensitivity. Now, there are more chronic symptoms that often warrant ordering an abdominal X-ray, including constipation or reevaluating some form of a calcification, be it an organ calcification or a stone of some kind within the abdomen, and that can also be a less common or less urgent indication. Now, there are certain indications that are definitely not effective on an abdominal X-ray, namely gastrointestinal bleed or anemia, of which it can be very difficult to visualize the reason for a bleed, or a soft tissue mass, or a nodule or a tumor of some kind. In addition as well, whenever an abdominal radiograph is ordered and there's a vague gastrointestinal symptom that doesn't actually point to a specific location or cause a clear and present symptom presently, that can often be low yield and not yield any actual findings on the radiograph. Now, when an abdominal radiograph can be obtained, very similar to chest radiographs, there are definitely acquisition views that are performed, of which there are three main views that are commonly used, including upright, with AP standing for anterior posterior or erect position. This is the best view to look for free air or for air fluid levels, as it tends to allow the air to rise up superiorly and fluid to settle down inferiorly. There is supine, where the person is on their back, and then there's left lateral decubitus, which is a substitute for the upright or erect position when a patient is too ill to be able to stand straight up. Now, of these two views, the upright and the left lateral decubitus is most commonly the one that you'll be looking most closely at, especially for free air. The supine view offers different advantages for being able to, for example, more accurately measure the amount of bowel distension that's present. Now, in those images themselves, those are actually rather old-fashioned images, but you can see there actually that we are able to show approximately where the actual X-ray will be taken, as they use a visible light source to actually plot out both the center point of where the X-ray is being exposed, and also plot out which quadrants and make sure that we image everything relevant within the abdomen. Now, in terms of overall abdominal anatomy, obviously this is too far short of a presentation to be able to go through things in extreme detail, but this is really more a refresher on the keywords that are relevant when describing different parts of the anatomy. Very broadly, you can divide the majority of structures into things that are within the peritoneum versus those that are behind the peritoneum and the retroperitoneal cavity. The reason why this is particularly relevant is depending upon the distribution of findings, you may be able to better localize where the disease or condition is actually coming from. So some of the keywords there including duodenum, portions of the ascending and descending colon, which are specifically in the retroperitoneal space, and the pancreas, majority of GU organs including kidneys, ureters, bladder, adrenal glands, as well as some of the musculature at the back, including the large psoas muscles and the abdominal aorta. These are all retroperitoneal structures. The reason why this becomes particularly relevant in analysis is that if you see free air that is free within the peritoneum, it is much more likely that the source of air is not going to come from any of these retroperitoneal cavity structures. This is particularly relevant for portions of the duodenum, ascending and descending colon. So it can actually help you localize the source of free air if you know that a structure is retroperitoneal and does not communicate with the peritoneal cavity. Now, in terms of bowel anatomy, obviously we have the large bowel and the small bowel, of which there are various segments. Within the small bowel, we often divide it into the duodenum, jejunum, and ileum. And within the large bowel, there are various structures that are present that can be declared, including the appendix, the cecum, portions of the ascending, transverse, and descending colon, as well as specific corners of the colon. So, for example, the splenic flexure or the hepatic flexure, and obviously the rectum at the very end. Now, in terms of converting that down into the actual finding on the actual x-ray itself, people often find very easily the large bowel because it's usually in the expected positions there. You can see they're outlined. And the issue more so is actually with finding small bowel. One thing I will point out on these large bowel images is that you can see there in the splenic flexure on the left image that large bowel doesn't necessarily follow that kind of picture frame or rectangular shape to it. And depending upon how much or little large bowel a person has, that large bowel can actually take a very tortuous or redundant course. So that's actually very person individual dependent. For small bowel, on the left image there, you have one that actually has a very distended small bowel in an obstruction case. And then on the right side of the image there, you have something that's a little bit more within normal limits. You can see that when there is significant gaseous distension, it's very easy and quite trivial to determine that something is small bowel. But when there is no gaseous distension, the vast majority of the bowel loop segments are actually not going to be seen at all. They're either going to be collapsed or going to have fluid within them. And it's only very short segments that have a little bit of gas within. So that's a very common or typical appearance for small bowel. In general, it tends to favor the bowel appearance within the center of the abdomen as well. So some of the principles that we use to distinguish small and large bowel, obviously including central versus that picture frame location. We look very closely at the mucosal folds to determine. So there are two terms there, plica circularis and haustra. I'll show you some images of that coming up next. And as well, obviously, small and large bowel have different diameters, usually around 3 centimeters or less for small bowel, and between 6 or 9 centimeters for the colon. Finally, fecal content is very rarely going to be present in small bowel and usually indicates pathology, whereas for large bowel, there's always going to be some element of fecal content present there. So this is more closely depicting what plica circularis versus haustra look like. You can see there for those distended small bowel loops as well, the lines that are forming the plica, they cross the entire diameter of small bowel, whereas with the haustra, they only cross about halfway, and that can allow you to determine whether the distension or the obstruction that you're seeing, which bowel segment is necessarily in by using this kind of morphologic clue. There is a rule that is often quoted, which is an imperfect rule, something called the 369 rule, which basically says that for small bowel, 3 centimeters, large bowel, 6 centimeters, and for the cecum specifically, 9 centimeters. These are the normal or maximal allowable diameters to these bowel segments. Now, this is a guideline. It's not a very perfect rule. There can be exceptions that can be seen, especially particularly on CT, but this gives you kind of a good initial ballpark to begin to estimate whether you're dealing with significantly distended loops or not. A very important exception, and this is very easy to see on CT, is that if there is no gas, if there's no air within bowel loops, you're not actually going to see any see very clearly the walls or the diameter of the small bowel, and therefore you're not going to be able to apply that diameter measurement. So ironically, that left-sided image there, which is basically a gasless abdomen, there is no visible or barely any visible small or large bowel loops, is actually potentially an extremely highly concerning appearance for bowel film. And so you often see in those kinds of reports phrases like a gasless abdomen or there's paucity of gas. And the issue there can be that those small or large bowel segments are 100% filled with fluid and can actually be extremely obstructed or distended, and very much it can be you can underestimate the appearance of distension in that kind of a situation, which is usually why if you have a high clinical suspicion of obstruction, you're going to move on to that CT examination and order that instead, and that will be able to distinguish between fluid versus air much more in greater detail. Now, with respect to the other cavity of retroperitoneal anatomy, obviously there's not going to be as much that you can see very clearly on an abdominal radiograph. The two main structures that I've highlighted here in red and blue include the kidneys and the psoas musculature. The kidneys, I highlight that border there just so that you can get an approximate appearance of where normally positioned kidneys should be present. And those are the regions you're really going to focus on in order to find a non-obstructive calyceal kidney stone or a stone that's present within the ureters or the proximal renal pelvis itself. One thing to notice about that is that actually the right kidney tends to be a little bit lower than the left kidney. This is just due to the relative arrangement of internal organs and having the large liver on the right there that's actually pushing the liver down. Obviously, as well, too, regions of the bladder and the adrenals take their expected positions either above the upper poles of the kidneys and with the adrenals, and with the bladder right in the center of the pelvis. Now, those structures you're not going to be able to actually directly visualize because there's not enough contrast between the adjacent fat and an empty, hollow structure like the bladder. Or with the adrenals, there's just simply too many organs that are overlying on top to be able to clearly see the edge or margin. Now, the psoas muscles, those can actually be occasionally seen, especially if the film is appropriately exposed. And you can see the little arrows there that are marking out the lateral edges of the psoas musculature. And obviously anything that is osseous, including your lumbar spine, your pelvis, the proximal hips, and the ephemeral heads are very, very easily seen and assessed for disease or conditions. Your overall approach to abdominal x-ray begins very much like a chest x-ray. So coming from a clinical perspective, you're going to have obviously your clinical history as well as your physical exam findings as well. One thing to take note of is obviously if you're having a patient that's of a childbearing age and there's the possibility of pregnancy, you may have to perform a pregnancy test prior to performing an x-ray to minimize dose exposure to a fetus. Now, the same assumptions that you have to check for at the beginning of an abdominal x-ray examination are going to be exactly the same for abdomen as it is for chest. So you're going to have to make sure that you're verifying that you're looking at the right patient ID and you're looking at the right dates of examination. You're going to have to take a look at how many images that you have available to you, including the specific views and orientations, and how that affects your interpretation. If available, you're going to look at comparison or prior examinations so you can see if something has changed between a previous state and the current state. And obviously, you're going to verify your anatomic range and your image exposure. The range mostly being that you should be able to see up to the bottom of the left and right hemidiaphragms, and inferiorly you should be below the pelvic superficies, and ideally extend almost partially into the proximal femurs. And with respect to image exposure, how you evaluate that is that really you look for that soft tissue contrast, particularly over the psoas musculature, and being able to see that the x-rays have actually penetrated all the way through to be able to see enough detail within the vertebrae and also the adjacent muscles that are present there in the retroperitoneum. There's a mnemonic that can help organize the way that you look at one of these abdominal images. There's free abdo, and that stands for different categories of either looking for free fluid, looking for air, that's both air within bowel as well as air that is outside of bowel, bowel wall thickening, be it small bowel or large bowel, various densities and calcifications that you see within the image, and also obviously taking a look at the various organ regions directly to look for any abnormalities. The presence of free fluid is again can only usually be seen if there is a large amount of fluid within the abdomen, but what you want to pay attention to, particularly when the patient is supine and lying on their back, is at the left and the right flanks. So on the lateral margins of the image, you're going to see much more white opacity that's there, that's representing the thickness of that fluid that's present in those cavities. And you're also going to see as well the relative mass effect. That fluid is actually going to displace and push a lot of the bowel loops preferentially towards the center and away from the edge. So that can infer that there's a large amount of fluid that's within the peritoneum. With respect to air, again, we kind of conceptualize this into two different categories: intraluminal air versus extraluminal air. Intraluminal air within either small or large bowel. Obviously, to measure small or large bowel, you need some air present internally, and a normal amount of air is always constantly present. You should know that the diameters that you're measuring, so that previously what we said was the 369 rule, it's much more accurate on supine view, and you actually have a reduced diameter on upright or erect view. And obviously as well, seeing that there's distension within bowel and the air that's present within can tip you off to something that is wrong within the exam, but it may not give you the exact cause for why there is sort of that bowel distension appearance. There are only very specific situations involving volvulus, a intestinal hernia of some kind, or a very rare condition known as gallstone ileus, where a gallstone has caused an obstruction, where you can actually nail down the exact precise cause. Many of these obstructive appearing abdominal radiographs, have to proceed on to another examination like a CT of the abdomen and pelvis to determine exactly why there is that obstruction. Now, the much more alarming finding of extraluminal air, this is air that is outside of the expected locations of the stomach, the small bowel, or the large bowel, is obviously a very serious finding, particularly if it's unexpected or particularly if the patient has not had a recent operation or procedure and could unfortunately indicate gastrointestinal perforation. Now, when looking for extraluminal air, obviously you're going to be able to be more sensitive to this finding in the upright, erect, and decubitus views. In the supine view, what happens is that air actually moves anterior almost towards the belly button region, and it spreads out entirely and very evenly across the entire abdomen, making it very difficult to find free air when you're lying in supine position. Further to the different findings, obviously having the presence of multiple air fluid levels in erect or upright position can indicate to you that there is almost as a stasis. The fluid is not really flowing appropriately through small bowel. It can also give you a good, reliable, large caliber diameter that you can see there. So this is a very typical appearance of a small bowel obstruction. Very rarely, in terms of specific entities, you can have specific signs. So this is something known as the coffee bean sign, which is made by that distended large bowel loop that's present, which is actually forming a sigmoid volvulus. And that appearance, again, can be extremely ominous, not simply just because of the distension, but as well that the distension implies that there may be compromised blood flow to that large bowel, raising it and giving it a higher risk of perforation, ischemia, and potentially sepsis and infection for that patient. This is an image of, on the left there, very large amounts of free air, which is a very uncommon finding. I think the thing to appreciate in that image is that you can actually see that it's quite lucent all the way out to the very edge of the abdomen, up to the diaphragms, out to the very edge again. You can actually see nearly a significant amount of air going to almost all edges of peritoneum. But that's a very severe form and not very commonly seen. The much more common manifestation is obviously in an upright pose, being able to see amount of air that is present either near where the right hemidiaphragm is or in the epigastric region. And that's a much more typical appearance for free air. Now, the vast majority of the time that we see that finding, there is actually a known cause. So the patient has either underwent exploratory laparotomy, some kind of a surgery or recent procedure. They're post-op day 2, day 3, and that is not actually a particularly surprising finding. If, however, a patient presents with acute symptoms to a clinic, to an ER, and has this finding as their initial workup with no previous or recent history of surgery, then obviously we now have to start a much more thorough investigation to figure out where exactly this potential intestinal or gastric perforation is coming from precisely. Now, that same finding of free air can also be seen, as we've mentioned, on decubitus view. And more precisely, the most common view is something known as left decubitus view, where the left side of the body is touching the bottom of the table, and the right side of the body is actually pointing up superiorly. And there you can actually see there's a flat line forming that free air, as air tends to always rise up superiorly. What this position, left decubitus, tends to do is that it maneuvers the free air to that surface between the liver and the diaphragm. So that actually lets you more confidently see or more confidently determine that there is free air within the abdomen. If you were to invert this 180 degrees and actually place the right side of the body touching the table, what you'd see is obviously that free air would move up towards where the stomach is, and it can be extremely challenging to distinguish between air that is in stomach, which is a normal finding, versus air that is outside of the stomach as well. So for this reason, left decubitus position is preferred if you're looking for free air, and it makes you more sensitive to be able to detect smaller amounts of free air. So there are very specific signs of free air that are given very famous eponyms. One, for example, here is Wriggler's sign, where air is actually seen in the bowel wall, visualized on both sides. So both within the intestinal loops as well as outside of the intestinal loops. That's indicated by those yellow arrows that you see there in that image. And obviously, a large amount of air along the hemidiaphragms, both on the right and on the left, can form something known as a dome sign, which is fairly self-evident. Now, air can be in different compartments. So one very concerning appearance is something known as intramural gas or pneumatosis intestinalis, which is actually air that is trapped within the bowel wall itself. you can see there in that red square that you have almost like a pair of lines where it's almost as if the bowel wall itself is thickened and there's a curvilinear track of air that's present within the wall itself. And fundamentally, that's always due to a breakdown of the bowel mucosa that lets air track into the bowel wall itself. Now, in its most severe forms, the causes of this appearance can be things like bowel ischemia and bowel necrosis. That's the reason why everyone is usually extremely concerned when they see this appearance. In a neonatal setting, which is the image that we have here, you can have neonatal necrotizing enterocolitis. So that is also, again, similar thing about how you have breakdown of that bowel mucosa, and that's where that air is tracking into. Even very relatively benign things like steroid therapy, undergoing a colonoscopy, severe bowel obstruction with that distension, as well as infection and sepsis can cause this. There are also sometimes very benign idiopathic reasons for pneumatosis, where a patient will have this appearance and it chronically reappears on multiple abdominal radiographs or on CTs. Because of the most severe causes, namely being bowel ischemia, usually this is the more benign causes or diagnosis of exclusion. So you assume it is a necrosis or ischemia until you can safely exclude it in a patient. Air can occur or be present in various tubular structures, obviously within the abdomen. So here we have some air that's overlying where you expect the liver to be. And this is actually portal venous gas. You can see that branching pattern of air that's present within the portal veins, both and predominantly in the right lobe, but maybe tracking a little bit into the left lobe as well. Now, this is most commonly due, again, to bowel ischemia or infarct. So as the bowel mucosa actually breaks down and air gets into the wall of the bowel, some of that air will actually be absorbed and collected into the portal vein system and track itself peripherally into the liver. One key thing to note is that you can see that this branching pattern, it tends to move to the edge of the liver itself and moves to the periphery. And that's a very important point because there is a confounding finding known as pneumobilia, which is where there is air that's present within the biliary ducts. Now, the main distinguishing feature, because this also has a very linear and a branching appearance, is that this is generally central in location. So it's more so at the porta hepatis, at where the common bile duct is, and very central in the liver. As you move to the periphery, you very rarely see this branching pattern. Now, the other reason why this is important to distinguish is that obviously the causes are extremely different for pneumobilia, and oftentimes it's iatrogenic. It's caused by a procedure like a sphincterotomy, an ERCP procedure, and air is introduced into the bile ducts because of that. There are very rare causes of pneumobilia, including a gallstone ileus, where a gallstone has actually gone straight through the common bile duct and caused a widening of the papilla. Obviously, erosive ulcers either in the stomach or the duodenum can kind of erode into biliary ducts, causing an air communication or a fistula, and any infection within the biliary duct system, like a cholangitis or emphysematous cholecystitis, all these very dangerous conditions can also cause a pneumobilia as well. But most of the time when you take an abdominal radiograph, it's usually due to something that we have performed, like a sphincterotomy or some sort of a procedure to the biliary ducts. Now, bowel wall thickening is a very challenging interpretation on an abdominal radiograph. Fundamentally, basically, there's a thickening of the bowel wall folds, so it looks as though even the plica, the haustra, have been indented in some way. This is most commonly called for large bowel, and effectively any etiology that can cause an inflammation or an infiltration of the bowel wall can create this thumbprinting sign. You can see there in the differential diagnosis of a thumbprinting sign, anything from chronic inflammatory bowel disease like an ulcerative colitis or Crohn's disease, a very severe infection like C. diff, bowel ischemia, diverticulitis, hemorrhage, but also infiltrative conditions like lymphoma, amyloid disease, or typhlitis, which would be more of an infectious disease as well, right, can cause that thumbprinting appearance. So here we have some very severe forms of thumbprinting. You can see there that it's almost as if there's been a formed indent of the large bowel in the transverse colon in the left two images. And on the right side there, I've just put up the normal reference. It was that picture of the haustra that we had seen earlier. And you can see how very much it forms like almost like a partially collapsed line. And that can help you pick out that maybe there could be inflammation in that segment of bowel, and it could warrant further investigation. Finally, with respect to calcifications again, it's important to understand that there are normal calcifications that you expect to see within the abdomen. There are calcifications that can actually be the cause of the problem itself. So something like a biliary stone or a renal stone, a calcification within the appendix, for example, right? As well, calcium can also be seen, not to say that the calcium itself is the disease condition itself, but it's a secondary situation. So for example, if you were to see multiple calcifications over the pancreas, that can indicate that the person has a chronic history of pancreatitis. It's not to say that the calcification is a problem in and of itself, but it leads to or points to a secondary condition that may give you a clue towards a diagnosis in the examination. So just to show you some examples of calcifications, here we have some pelvic phlebolyphs. These are actually tiny calcifications that are within veins in the pelvis. What happens is that these tiny little veins, they form a blood clot, and that tends to harden and calcify over time. Now, visually as a finding, this is important to know that they exist because it can be very difficult to distinguish this from a renal or a bladder stone or a stone that's within the ureters, especially the distal portion of the ureter as it inserts into the bladder. So you have to kind of get used to where these typically are along the periphery of the pelvis, and also sometimes the shape can help you out because it forms a linear or a vascular shape that would fit the expected course of where a vein would be. There can be masses that are extremely calcified. So within the pelvis, by far the most common calcified mass that you would see would be a uterine fibroid. So these are soft tissue masses of the uterus that often have a very classical appearance, what is termed a popcorn calcification. Could be quite large, quite impressive, but usually these are chronic and long-standing findings you see in multiple prior examinations. Finally, obviously even vascular structures can also be calcified as well. So here we have a calcified abdominal aortic aneurysm. These calcifications are really within the wall of the aorta, and these are the atherosclerotic calcifications that you see. They take on almost like a curved shape. You may not be able to see all walls of the aneurysm, so here you can only see the left side of the wall, but the right side is overlapped with the vertebrae, so you can't really see that line nearly as clearly. Now, the important thing to note about this is that although this can tell you that there is an aneurysm that's present, they don't permit you to diagnose specific complications, such as an aneurysm rupture or a dissection, which would require to look at a soft tissue flap that's inside of that calcification. So the conditions and diagnoses that you wish to make can't be successfully excluded using just this radiograph. You have to oftentimes order a more advanced exam like a CT scan, and on top of that you have to order it with intravenous contrast so that you can see that dissection flap, or you can see the hemorrhage and blood that's come out for an aneurysm rupture. So in summary, very similar to the beginning of the approach to a chest x-ray, verify patient ID, technique, and various views before beginning interpretation of the images. Using that mnemonic free abdo for free fluid, air, be it in bowel or outside of bowel, densities and calcifications in organs, go in a systematic manner, interpreting all of the various images that you've been provided with. Obviously, abdominal pathology is much more vast than what can be shown here in a short 30-minute presentation. But this will hopefully provide you with an opening approach to interpreting abdominal radiographs. The subsequent unknown 20 cases and subsequent review sessions that we'll be having shortly will expose you to a much wider variety of pathology specifically, and how to make relevant findings in all of those various conditions. As usual, we always welcome feedback. If you have any questions, both about this presentation or about the transition to clerkship, or anything concerning either medical imaging or radiology, always feel free to reach us at our various email contacts, and we'll be happy to take your feedback as well as any questions that you might have. Thank you very much.